Welcome everyone to another FSE radio episode. I'm here with Thimo, and today we have Dr. Henk Groen with us, an epidemiologist who specializes in the field of reproductive and perinatal health. He is co-leader of the research program Reproductive Origins of Adult Health and Disease, and used to coordinate the course in chronic disease epidemiology. I am particularly excited about this episode as I am interested in pursuing a career in public and global health and understanding distribution of disease. So it's a very big honor to speak with you today. Thank you for joining us.
You're welcome.
So, just to get to know you a little bit, have you always had an interest in reproductive and perinatal epidemiology?
No, not really. I consider myself to be sort of a late bloomer in terms of epidemiology. I have a long career in research, but not all of that was in epidemiology. Looking back, it was epidemiology when I did my own PhD, but I didn't know about it at that time. So I only realized that it was epidemiology when I got to work at the Department of Epidemiology. But it really sparked my interest when I came to work there. I was working in cost-effectiveness research for a while at that time. And, well, I liked it, but it was not scientific enough for me. And then the group that I worked became part of the Department of Epidemiology, which was formed in the UMCG around 2005. And I thought, well, this is my opportunity to go more in depth in the research part and to specialize in epidemiology. So I was able to do that, to get official recognition as an epidemiologist with some additional efforts. And soon after that, I found my way into what I'm doing at the moment.
Yeah, so it was the lack of scientific research that you kind of wanted to fill the void a little bit.
Yeah. Yes, that's true. Yeah, that's right.
All right. And being an epidemiologist, involved in public health, how interdisciplinary is your work? I assume very from what you've told me. Yeah.
Yes, that's true. It's very interdisciplinary, and that's also what I like about my job. I work a lot. My main interest is in clinical epidemiology. Mm-hmm. So public health epidemiology is a little bit on the side, but mainly I work with clinicians. So I work with clinicians from various departments, like obstetrics and reproductive medicine, but also pediatricians. I also do some work in early childhood. So I like that aspect a lot, and on top of that, I also do that quite a lot in international settings. So I work with people from other countries, which I also really like. You could say, well, it's quite interdisciplinary, yes.
Maybe just in between. So what is epidemiology exactly? Because maybe that's important to state, actually.
Yeah, that's a good point. Epidemiology is actually very broad. It's much broader than most people think. If you're on a birthday party and you say you're an epidemiologist, and people think, oh, you're from the infectious diseases.
Yeah,
but it's not just that. It's all infectious disease is only a very small part. Epidemiology is much broader. It's basically everything that has to do with your interest, distribution of diseases in populations. What are the risk factors? How do you evaluate treatments, things like that. And it can be as broad as, cancer. So cancer epidemiology is one field. There's a field of lifestyle medicine, for instance. And so nutrition, which I also do a little bit on. We in our department at the UMCG, we have specialists on all of these areas.
And what is then perinatal and reproductive epidemiology? Because that's still very broad in a way.
It is broad, but it's basically doing research on risk factors and treatments in fertility, in obstetrics, so pregnancy and childbirth, and early neonatal period, and so the first maybe 2 years of life. That's also why I work with the specialists in these areas, and so the clinicians in these departments are my colleagues. And well, actually, the broader context of our research program that you already mentioned, so the reproductive origins of adult health and disease, is even broader than that. So I'm only on a very small area within that program, but my main focus is on these, and so on fertility, pregnancy, childbirth, and early child life.
Yeah. So women's reproductive health mainly kind of.
Things like that. Which women get complications during pregnancy. What can you do to treat them in the best way? Which women respond to fertility treatments in the best way? Things like that.
So it's kind of used to predict, based on like a whole statistics of many women, what women kind of get which problems, or sort of.
Yeah, sort of. Of course, you in the end you want to use your knowledge in a way that's beneficial to the patients, to the women, to the children. But also a large part is also just looking at data and finding out risk factors. And because if you don't know what the risk factors are, you don't know what the possible handles are to design a treatment. So you want to have a complete picture, basically, of what are the risk factors, which women are the most susceptible to certain outcomes, so that you can maybe do something about it. And so you can either make an intervention, or you can make a prediction and say, well, you have a high risk, so you should do this. So you should have an intervention, or, something else.
What are the trends that you then tend to see? What is the most common factors maybe that play a role in, reproductive perinatal health and disease?
I think you can say that lifestyle is a very important factor also in reproductive medicine and in perinatal health. The global pandemic of overweight and obesity plays a role there also. We know already that being overweight for women has negative effects on their pregnancy chances, so their ability to get pregnant and also to have an uncomplicated pregnancy. And on top of that, we really are still collecting evidence and information about what does it mean for not only the pregnancy itself and the child immediately after birth, but also in later life.
And what about social cultural factors? Economic factors, political factors. I assume those have an influence as well.
Yes, certainly. Yeah. They are very, I think maybe one of the biggest challenges are these kind of factors. And so both from a health risk point of view, and so people who are from poor socioeconomic backgrounds have poor understanding of their own health. What does it take to be healthy? Maybe they don't have enough money to buy healthy foods, and the cheapest foods are not the healthiest ones. So that's certainly one aspect, and the other one is that also we of course, when we do research, we try to include everyone. We try to do research on a representative sample of the population that we want to serve with this intervention. But what we see is that most of the time the people who participate are the highly educated people, because they understand the information that they are given about the study, because we have to tell them what we are going to do.
Like a volunteer bias.
Yes,
Yeah.
well, we are. I think we're not good at providing the information in such a way that everyone is able to understand, and that, well, introduces another, you could say, bias in that the results that we eventually get are not necessarily true for everyone, but only for the people who participated and who are a subset of the population, not completely representative.
And is it then so that the social, cultural, economic, political factors influence lifestyle, and then that influences the health outcome? Because I imagine there's like a interplay of all of these kinds of determinants.
Yes, there is, and that's well. Of course, that's something that we try to disentangle in epidemiology, and so we try to collect, and we collect information, we collect data, and we try to make sense of how do all of these factors, well, act together. But it's not always easy, especially if, things that are very closely related, and it's not always easy to determine which happens first and which happens next. So what was there first? Was it first low socio-economic status? Then there was poor nutrition, maybe overweight, or is there some other pathway that we do not see?
And how did you go then and find, if you know like which one is, and don't know which one is first, how did you discover which one would be first? How did you try to discover that? Which one is the cause, basically?
Yeah, that's a good question. There are some methodological solutions to that. If you have the right data, you can try to find out which factors exactly influence a certain outcome or the risk of an outcome, and whether these effects are direct effects or indirect effects, so through other factors. So you can make like a graph of all of the possible effects that you think are there and try to perform an analysis that takes into account all of these pathways. That's, if you have the right data, that's possible. Other possibilities are just to maybe try to do an intervention at some point in the cycle, in the pathway that you think is there, and try to see what happens if you do that. So you get a little bit more understanding of whether what causes what, basically.
What kinds of regions have the most difficulty maybe with the accessibility to reproductive health or perinatal health and care?
Well, in the Netherlands, you mean?
Well, inclusively, yeah, why not?
Well,
yeah.
Maybe we can start. We can start on a global scale, because there I think there are the biggest differences.
Yeah,
I mean, if you look at if you compare the situation in the Netherlands to situations in regions like sub-Saharan Africa or something, it's much worse there. I mean, women die there all the time of complications of pregnancy that we don't see anymore, because we have a much better organized healthcare system. So on a global scale, there are really very large differences. But also on a smaller scale, the differences are there. I think about, 15 years ago, it turned out there were numbers on a European level that compared perinatal mortality in all of the countries in Europe, and it turned out that Netherlands was not doing well. And so that caused a very big surge of research, meticulously looking at the data. Is it real? Is it really the case? And so maps were made of perinatal mortality on a national level, and also zooming in on smaller communities, smaller regions, and you can really see quite clear differences. Even in the Netherlands, between areas where there are many migrants, for instance, who maybe that have not had the right antenatal care, or if they are in the Netherlands and they get pregnant, they don't know how to access antenatal care here. But also even, within the city of Groningen, there are regions that have poorer perinatal mortality and better perinatal mortality. So it's nothing compared to the differences with the low income settings like in Africa, but if you look very closely, there are differences.
So once this study is conducted, like, okay, there's a lower in specific areas in the Netherlands or lower in the Netherlands compared to Europe, how generally is then this implemented? How is this like action taken in policy, or what's the next step there?
Of course, seeing these differences is only the first step. Yeah. So the second step is finding out why. Why is it? And a lot of effort was put into that, and it turned out that it was a sort of an interplay of several factors, as it is usually the case.
Yeah.
It ranged from communication, simple communication. So if a woman was, of course, in the Netherlands we have quite a lot of home births. If a woman was trying to give birth at home and it wasn't going well, then she had to be transferred to the hospital. The communication between the midwife to the gynecologist in the hospital was one of the weaknesses. So this has been improved a lot. So after that was recognized, it has been improved. Another thing was that it turned out that compared to a number of different countries, other countries, we had not such good ways to monitor the health of the child during pregnancy. And so you can do ultrasound measurements during pregnancy to see if the child is growing well. That was not as advanced here in the Netherlands as it was in other countries. And it had to do with the approach that we have here, that, pregnancy should be, it's a normal thing, right? And it's healthy. It's not a disease. Pregnancy is not a disease. So, but it turned out that if you monitor closely, you find out you pick out the ones who are at risk earlier, and you can do something about it. You can monitor them closely, or say at some point now you have to come to the hospital because it's not a good idea to give birth at home. It's better to go to the hospital. So a lot of things happened after this was discovered. It was really a big effort from everyone in the perinatal healthcare system.
Yeah. I think this actually connects to one of my other questions. I think you co-wrote a paper on micronutrient deficiencies among women in low and middle income countries. Mm-hmm. I think it was Indonesia.
Yes, that's right. Yep.
So, I saw that it concluded that the implementation of the multiple micronutrient supplements via health centers, that the adherence to actually consuming those micronutrients was low. Mm-hmm. And then that was problematic. So in that case, you do kind of have a set, a rule of what you should adhere to, what will help you and what would help women in pregnancy. Mm-hmm. But then, what are the difficulties encountered with maybe adherence to it?
Yeah, that's really very different according to where you are, first of all. But I think in the case of Indonesia, we were able to do our study on a pilot that was done to implement this multiple micronutrient supplements. We call it MMS for short.
Yeah. It's easier.
So the Indonesian government had an idea. Well, maybe it's good to provide that to pregnant women, and they started on a small scale, which is always a good idea if you do something like this. And we were able to piggyback basically on this pilot and say, well, okay, so if you're going to do that, we are going to collect data to see do all the women actually get the MMS? And if they do, how many of them do they get? And what is the effect on some parameters, some ways to measure whether the pregnancy is going well? So the Indonesian government had more or less already decided that they wanted to implement this, but they started on a small scale. But, well, because of the small scale, we had the number of problems that could happen we didn't have, because Indonesia is a very large country, many islands, so just getting the tablets everywhere can be a challenge. We didn't have that problem, but still we had a problem of reaching all women, and also I think women where the pregnancy was not so closely monitored, so maybe living more remotely, they were more difficult to catch.
Is it then related to maybe like the lack of education on particular, diseases or health-related subjects?
Yeah, maybe it is. I think there's always a lot of, beliefs, you could say, around pregnancy. Yeah? So every culture has their beliefs around pregnancy, and that can play a role. I mean, women who had maybe already a previously successful pregnancy without the MMS, they think, well, I really don't need it. Where actually they may need it more because of they have a second pregnancy, and some of their micronutrient stores may be depleted because of the pregnancy. There are experiences of women who say, well, I had tablets in my previous pregnancy and they made me sick. So I had to vomit a lot, even though they probably were different tablets, because this was the first time that these particular tablets were supplied. And we know from other tablets, especially with lots of iron in them, that women don't like them. So there's all kinds of these beliefs that you have to sort of fight in a situation like this. So to make sure that women are convinced that it's good for them to take the MMS, which we believed at that time and which we have shown now to some degree that it's actually beneficial.
Yeah. And, it also made me think of the midwife to hospital communication example.
Mm-hmm.
So, I mean, generally, I assume it would be good to be knowledgeable of maybe the difficulties of, implementing the policies.
Mm-hmm.
But in terms of education, as an educator yourself, I assume you would believe in its effectiveness.
Yes, of course, yeah.
So maybe could you tell me a little bit more about that? So how can we properly and effectively convey, knowledge about women's health, for example?
Yeah, I think you almost cannot start too early with that. Mm-hmm. I was involved in this studies or this evaluation of the low or the high perinatal mortality for a while, and people think that starting at a very early age with education about sex, about that what it means to have a child. It's very important to do that. I mean, we know more and more that it's very important for a child to have a good start. So we now recommend women, if you want to get pregnant, you're not pregnant yet, but if you're planning to get pregnant, this is what you should do. You should take folic acid. You should avoid certain things. That's all very important. And many young people don't know that. And I think that's important to teach them about it, to educate them about it. And another aspect related to the communication part that you mentioned is also one of the things that changed since this evaluation is that also at the level of education of midwives and obstetricians, there is more communication. So they have joint education sessions to understand better from each other how they work, because they have to work together at some point. So they have to know from each other what they do, why they do it. And there is a discrepancy in the Netherlands. The midwives, they believe in natural birth. The obstetricians, they see the difficult cases, so they're maybe not so convinced. So it takes communication and knowing about what everyone does.
You talked about the mistakes in communication leading to difficulties. What are these mistakes in communication exactly? You said just mistakes. What often goes wrong there, or is it just generally a lot of different things?
Yeah, well, I think it's in many different areas. I think it can be simply that, let's say the midwife, she measured blood pressure, but she didn't mention it to the obstetrician. Maybe she found high blood pressure at some point, but it was not mentioned. Also, in the other direction, so from the obstetrician to the midwife, maybe they don't ask the right questions. So what really helps is to have a shared medical file, and so an electronic file that they can just exchange and that has all the information in it. And it's not only a problem for the communication for the midwives and the obstetricians, but it's also very alarming for the women who are in labor and they have to go to the hospital, so something is wrong. And they get there, and then there's the midwife and the obstetrician, they talk to each other for a while, and then the obstetrician comes and starts asking questions. That's the pregnant woman says, well, why don't you know that? Because I told everything to my midwife. So that's also, it's stressful. It adds to the stress that is already there.
I would imagine, yeah. That's
major miscommunication.
Yeah. And then you think, well, am I in the right place here? Because nobody knows what's going on, what happened to me. Yeah. And well, I heard some stories from women who experienced this, and it's really, very, very stressful.
Yeah.
And because, well, often they don't notice anything themselves, but they go to the midwife and, they start to frown and they think, well, I'm not sure I can get this measurement right. And then, the stress starts to rise, and it's really, really stressful.
Yeah. Frustrations in women's health, fairly common.
Yes.
So in terms of, these methodological challenges, is there research being done on how to improve it? Also, not just in terms of communication, but how we can effectively educate, or how we can improve, research that is maybe being done.
Yeah, I think there's a lot going on there. It's, I think the most important aspect is that you realize what kind of information you need, what kind of data do you need to investigate your problem, and to collect it in a systematic and in a reliable way. To be able to answer your questions, and because if you are interested, in a certain aspect, let's say influence of smoking during pregnancy, and you have data sets where only 20% of the women report whether they're smoking or not, then it doesn't get very far. So you really have to make an effort to get the right data, and then it's much easier to tease out what's going on. So what are the risk factors? Yeah,
I'm I took a course in psychology this block, so a little bit different from medicine, but we had a course on individual differences. So do you see that that is like a very big problem in epidemiological research? Or do you really focus on group data and not really on individual deviations?
Yeah, well, I think at first we usually look at large groups, and so we try to find what's the average problem, or what's the average degree of the problem. But at some point you have to zoom in. To give you an example, we did a large study on a lifestyle intervention in women with overweight who had trouble conceiving, so getting pregnant. And we had this, we thought, very nice intervention. Some aspects, getting women to move a little bit more, looking at their nutrition, giving some counseling. So we thought, oh, that's okay. But it turned out it was okay for some women. But interestingly, especially women who had previously tried to lose weight, they didn't respond very well to our intervention. And we think it's probably because they thought, well, I tried this before, and for me it doesn't work. And that's something we never thought of beforehand. But afterwards we saw, well, it's working, but not as much maybe as we thought it would. Why is that? And it turned out that, there are some individual characteristics that make you more likely to succeed, more likely to achieve weight loss and to achieve a pregnancy than other characteristics.
So adherence really depends on history, also with the MMS example.
Yes.
Okay.
Yeah.
Okay. I actually wanted to, step back a little bit because we were talking about, perinatal health. So we mainly talked about the factors in women, obviously, that affect how successful their pregnancy is.
Mm-hmm.
Do the fathers have a role in this?
Yeah, they do. Yes. Yeah. I'm glad you brought it up because it's an area of research that is now taking off. Really, we have one of our reproductive medicine specialists at the UCG is specifically interested in that aspect. And we used to think, well, it doesn't really matter what the father does. But we know now that it does matter. And also, for instance, overweight, men with overweight have poorer sperm quality. So they have less chance to conceive with their partner. And, we know that age also plays a role a little bit, although not as critical as for women. But there is more and more research going on into that. And especially, if you talk about lifestyle interventions, so interventions directed at overweight, it's quite a lot of the time it's a problem for the mother as well as for the father, because the overweight, maternal and paternal overweight, they correlate. So you can say to the woman, you have to lose weight, so you have to change your diet. But if they are at home with the two of them, then it means that it's easier, of course, to both change their diet. And if they are both overweight, that's doubly beneficial.
So relational dynamics also, I guess, would influence.
Yeah.
And I guess the quality of the relationship as well.
Yeah, that's true. We know from our data in reproductive medicine that going through the process of IVF is stressful for a relationship. It's not uncommon for relationships to break up during the trajectory of being evaluated for treatment and starting treatment. So it's really a difficult time in a relationship. So that has to be taken into account.
So do we know how the health of the man impacts the health of the child? Like, because obviously this wouldn't be expected, right? Because it's just the sperm that's sent there. Only genetics, right? You would expect, right?
Yeah. I'm not fully informed of all the latest developments there, but it is true that the effects from the maternal side are really big. I mean, and the oocyte, and so the egg that has to be fertilized, it comes from the woman. In fact, the oocytes are already formed before birth, so they can also be influenced by what's your oocytes could be influenced by what your mother did when she was pregnant with you. So it carries across generations, but we know from interesting, sort of natural experimental studies that the oocyte and the condition, the nutritional situation of the mother at the time of conception is very important. And because the fetus, or the embryo actually is not a fetus yet, but if fertilization takes place, the embryo starts to divide and more cells start to form, and it has no nutrition by itself. Well, it has only the nutrition that's in the egg, nothing from the outside. And so it takes a while for the embryo to nestle into the uterus, into the womb, and then the nutrition from the outside starts to get in. But the first period, it's only what's in the egg. So that's very important. But that being said, we also know more and more about genetics and about also a very interesting field, which is epigenetics. And so the way that DNA is used, at various stages of life, it's quite easy to imagine that also at the level of the sperm that makes a difference.
Yeah, I would imagine that health could indeed impact epigenetics, which actually could impact something.
Yeah.
So that's makes sense. Yeah.
Yeah. Yeah.
Another thing I noticed when I was doing my research was the mentioning of pre-eclampsia.
Mm-hmm.
What is that? It was very frequently mentioned.
Yeah. Pre-eclampsia is a condition where the mother develops hypertension, so high blood pressure, during her pregnancy.
Okay.
And it's a very, potentially life-threatening complication. And especially in the low-income settings where women are not adequately monitored, it's a very important cause of death of pregnant women, because the hypertension has the tendency to increase. So the longer the pregnancy lasts, the higher the blood pressure gets. It starts to affect the kidneys, it starts to affect the liver, and it also, in the end, can cause seizures. So the health of the mother is really jeopardized. And that's why a lot of research is done into that. Especially in low-income settings. I mean, we also see here pre-eclampsia, but at a much lower rate, I think about 3% of pregnancies. But because of the potentially life-threatening nature, it's a very important complication.
So the monitoring of it is a problem. I guess maybe obesity would influence. So what are the factors that could then maybe cause high blood pressure and be extra, detrimental to pregnant women?
Overweight is a risk factor. There's also clear differences between ethnicities. For instance, black women have a much higher risk of having pre-eclampsia than white women. I don't know exactly the background of that, but it's very clear from epidemiological data. And we also know, for instance, that if you have pre-eclampsia in your first pregnancy, you're much more likely to get it in your second pregnancy than someone else. We also know that the higher the blood pressure was in the first pregnancy, the higher your risk to get it in the second pregnancy. And a very interesting thing is that we also see that women who had high blood pressure during their pregnancy are also at higher risk of getting high blood pressure later in their life, so outside of pregnancy. And we don't really know why that is. We think it could be that, the pregnancy is basically sort of a stress test for the cardiovascular system. And so if you are prone to develop hypertension, it will show during a pregnancy. So it's just two manifestations, and the pregnancy is just a manifestation of your likelihood to develop hypertension later in your life. But there's also some evidence to suggest that actually going through a pre-eclampsia increases your risk. Is a mechanistic risk factor for hypertension, maybe because of damage to the kidneys, for instance. So in more aspects than one, it's a very important complication.
So it kind of has feedback on itself, right? If you can have more high blood pressure. If high blood pressure, you can have more pre-eclampsia.
Yeah.
Yeah.
Do women of certain ages experience that more? I assume maybe older would be more at risk.
Yeah.
Or is there no clear trend there?
I'm not sure if that's true. I don't know the evidence for that. Maybe it is true. I just don't know.
Oh, it's just an assumption. Yeah.
Yeah. If I had to make a guess, I would probably think so. But I have to say I don't really know. Other than having had a previous pregnancy, of course. And so if you have your first pregnancy at 37 instead of at 30, then I don't know if you have a higher risk of preeclampsia at 37. But if you had previous pregnancies, and maybe the one at 37 is your third, and maybe you had clinically recognized hypertension in one of the previous pregnancies, then it's clearly increased. But then it's not an age effect, it's only an effect of the previous pregnancy.
Do problems experienced in the first pregnancy often show up in the second? Or can they still be experienced in a very different way?
I don't know.
Because with preeclampsia, right, like it's likely to come around the second time.
Yes. Yeah. I don't know if that's true for many other things.
Okay.
I haven't done any research on that.
Mm-hmm. That's fine.
But I don't know.
Okay.
Good scientific to say, I don't know.
Yeah,
right?
That's a perfect answer.
Something that ChatGPT cannot.
Yeah.
Exactly.
It will never say I don't know.
Exactly, yeah.
So what do you then think are the biggest unanswered questions in perinatal epidemiology?
Yeah, I think we still have a lot to discover regarding the whole epigenetic processes that are going on.
Could you maybe give an example?
Yeah, well, I can give you an example, yes. A study was done not so long ago in the Netherlands, where in a fertility lab they wanted to switch from one fluid that they used to incubate the embryos to another fluid. And the embryologists are very, very cautious with everything that they do, and because they are they are dealing with human lives, with embryos. So anything they want to do, they want to make sure that it's not harmful. So what they did is they compared these two fluids for a while. And you have to know that in IVF, so in vitro fertilization, the embryos are cultured for about 3 days. So the embryos are in this fluid for about 3 days. And what they saw in the end was that there was a difference in birth weight between the embryos cultured in one of the mediums, one medium and the other.
Wow.
3 days, of course, in the very, very early stage of life, 3 days in a different fluid, and on average, your birth weight is 100 grams higher or lower.
Yeah.
We
don't really know why.
and also another example is that, in IVF, what is, the most common way is that you give hormones to the woman, so that the oocytes, they start to develop and they are harvested. and then they are fertilized outside the body. But of course, this whole, we call it hyperstimulation, and so we stimulate the ovaries in a very strong way to develop all of these oocytes, is very unnatural. And so the oocytes that we harvest, they are already a little bit maybe unnatural, but what we do, if we culture these embryos, we select one and we place it back after 5 days. The situation in this woman is still very unnatural because she is still having, higher levels of hormones than normal. And yeah, we thought, well, we have to do it this way. This is how it started. But now more and more people say, well, it's not what we should do. We should just keep the embryos for a while, wait for the woman to go back to her natural state, and in one of the next menstrual cycles, we place back the embryo. So all of the embryos are frozen, which is also not natural, of course, but at least you prevent that you place back an embryo in a woman who is, totally off the charts with respect to her hormones. And this whole regulation of the hormones. So I think there's still a lot to discover there.
So I guess there's many reasons maybe that IVF is has such a, well, not a very low success rate, but that it's, because it's so manipulated. Yeah.
And well, that's another thing. I think we still don't know why IVF is working in some cases and not working in others.
Yeah.
I mean, we in quite a number of a percentage of couples who start IVF, we don't know why they are not able to conceive naturally. And some of them achieve a pregnancy nonetheless with IVF, but some do not. And it's not always clear why it doesn't work.
I guess that's with biology. It's just like human bodies are very complicated, and we just don't understand enough to really manipulate it and to create this effect ourselves, probably, right?
Yeah, and well, to be honest, my personal, what do you call it? My conviction or my belief is that if we would have thought of IVF now, with everything we know about how important these very early days of life are, I'm not sure whether we would go ahead with it, because we're creating such an unnatural situation. It's like aspirin. Aspirin was a painkiller, and then at some point they discovered that it also prevents blood clotting. If that would have been known at the moment that they put it on the market, it would not have been registered, and certainly not in the current time frame, because it's a very serious side effect for a painkiller. Now they use it specifically because of this characteristic that it inhibits blood clotting. So it's now given also to pregnant women to lower the risk of pre-eclampsia.
Very interesting. Yeah.
So that's how it goes in science.
Yeah.
All right. I feel like we're nearing a good time to complete the episode. What is maybe one takeaway message?
Or something that you want to say to maybe more people to understand better about perinatal epidemiology?
Well,
hard question, I know.
It's complicated, I would say. Well, I think that we have to realize that there's still a lot we don't know, and we have to be cautious with all of this. I mean, it is new life that we are dealing with, and I'm very happy that there is more and more interest and emphasis on all of these things that we do around fertilization, around fertility medicine and obstetrics, to see what effects does it have on later life. And that was not the case when I started working here on this 20 years ago. but it's really become more important. And so we say, well, if we do an intervention to induce labor and to let the child be born, we should look at what it does. What's the effect? And I think we are doing that. So we're making steps, but we're not there yet.
There's progress.
Yes, certainly.
All right. Thank you so much
Thank you
for letting us do this interview, and we'll see you guys next time.
Okay.
Bye.
Bye.